published in the New York Times about a year ago. Deadly germs, lost cures. Urinary tract infections affect millions. The cures are faltering. So UTIs are a big deal, okay? They affect a lot of people. There's a lot of issues about how people are treating them appropriately and inappropriately, so it's a very important topic. So let's start with just the pathophysiology and kind of, I like pictures, so I always have a picture to show. So this is the female on the left, the male on the right. They're facing each other, okay? So as you see in the female, the bladder and the urinary system sits anteriorly just behind the pubic symphysis, which is why the suprapubic pain or tenderness, you know, is one of the symptoms of a UTI. From the bladder, the ureters go out on both sides up to the kidneys. The kidney sits up under the rib, so that's the costovertebral angle tenderness. So costo is the ribs, vertebral body is the spine, obviously, and so it sits right in that corner there. So again, with the female, the genital tract is right behind there. So this is the uterus and the ovaries, fallopian tube, and then behind there is the rectum. So, you know, first thing would be, like when somebody has suprapubic tenderness, it certainly could be in the bladder or cystitis, but it could also be endometritis or something else, a genital tract infection as well. So just keep that in mind. For the male, again, you have the urinary system anteriorly behind the pubic symphysis. Obviously don't have a uterus there, right? And you have the rectum back here, and again, the same, the ureter comes off into the kidneys. For the men, obviously there's the prostate, which isn't in the females. So that's at the base of the bladder right here where that sits. The first thing you note between men and women is the difference in the length of the urethra. So for females, the urethra is very short, and this is the red arrow. In males, it's pretty long to get to the bladder. So that is one of the main reasons why women have such higher rates of urinary tract infections than men. Now that changes as men get older and they get, you know, prostate enlargement and there's problems with urine flow, and or if they have catheters, that changes. But in young people, it's very uncommon for a man to have a UTI as opposed to a woman. So the other thing with men is that they can get orchitis or epididymitis, and the pathophysiology behind that, again, it's usually an ascending infection, so coming from the urethra up the urethra here, and instead of kind of setting up shop in the bladder to cause like a cystitis, it kind of goes through this ductus deferens and then comes over here and it infects the, you know, the testes or the epididymis, causing an epididymo-orchitis. So in young men, that would be more likely related to sexually transmitted infections, but in older men, certainly over the age of 40 or so, you worry about urinary tract infections causing an epididymo-orchitis. So that's just the pathophysiology there. So for any infectious disease syndrome, many of them have different states. So sometimes there's symptomatic infections, you know, where they have a true symptomatic infection. Sometimes the organisms involved can just cause colonization and are really not causing any problems for the host. And sometimes the organisms can pass through and be eliminated immediately without any colonization. And so for any syndrome, you have to consider the organism factors, host factors, and the environment to help explain why people end up in these different buckets. So I'm going to go through those things for a urinary tract infection. Oh boy, yeah. Okay, so I had a blue background before, so maybe some of the coloring will be a little bit different here. Oh yeah, sorry. And I should have used the Metro slides, I suppose. But okay. So first we'll talk about the kind of the host and environmental factors. So the first thing we talked about obviously was the short urethra in women for an anatomic reason. There may be some genetic factors why some people are more prone to UTIs than others, because there can be different attachment kind of receptors and things that might make it different, or inflammatory responses. So there is a component of that, most likely. It's still being kind of evaluated. But then the big issues here are related to the urine flow. Okay, so you can have structural problems that inhibit the normal flow of urine, or you can have functional problems that inhibit the normal flow of urine. And both these things create a risk factor for getting infection, because when there's not normal flow, things back up, bacteria replicate, they cause problems. So these factors, pregnancy, stones, an enlarged prostate, these can all be kind of obstructive structural issues. And then more of the functional issues are related to neurologic dysfunction, spinal cord injuries, or other kind of neurologic issues that lead to ineffective emptying of the bladder. The behavioral environmental factors include things like sexual intercourse, use of catheters, antibiotic use, spermicides, postmenopausal changes where there's change in the hormone in the perineal area and loss of protective lactobacillus. And this all relates kind of to the normal bacterial flora, the microbiome in the perineal area. And these things can alter that composition and throw things off and lead to an increased risk of UTIs. So the microbiologic factors, I mean, some organisms really don't cause UTIs at all, and other organisms are very common to cause a UTI. And this can be related to a number of factors related to the organism itself. So some examples here would be E. coli. It's the most common organism to cause UTIs, especially in young women. And some of the virulence factors that E. coli has, and certain strains of E. coli, is that they have these pili that allow them to adhere to the uroepithelial cells. They also can produce like these siderophore, different compounds that allow iron to get into the organism to allow it to survive and replicate more. Klebsiella can have this mucoid capsule, which allows it to evade kind of the host defenses a little better. And then Proteus has this a urease, so an enzyme that converts urea to ammonia, which increases the pH of the urine, makes it more alkaline. And that causes precipitation of like calcium and magnesium ions, which leads to these what we call struvite stones or stones, which is very common for Proteus. So those are kind of some examples of the virulence factors for certain organisms that cause UTIs. So in terms of the microbiology, most cases of uncomplicated UTIs in young women are related to E. coli, 80+%, 80 to 90%. Oops. Yeah, this is all off a little bit. I'm not quite sure why, but this should circle Staph saprophyticus. So 10 to 15% of uncomplicated infections in young females are Staph saprophyticus. So those are the two big organisms for young females. When you get into more complicated infections, so people that have either any of those structural or functional abnormalities, you tend to see some of these other gram-negative organisms, Klebsiella, Proteus, et cetera. Yeah, it's all a little off. I'm not sure why, but TB can be associated with sterile pyuria in association with high-risk epidemiologic risk factors. So just because someone has sterile pyuria, don't jump to gun and say, oh, we got to work them up for TB or something like that. It really is in coordination with kind of some high-risk epidemiologic risk factors. And then yeast, group B strep, enterococcus, these can be contaminants often or colonizers. And I'm going to show you some data with enterococcus and group B strep in particular, but Candida, yeast in the urine is usually kind of contamination, honestly. There can be rare exceptions. Maybe it would be from a hematogenous spread in the kidney or some very complicated UTI in somebody that has catheters and stones and is very sick and that sort of thing, but it's often just contamination. So this was a study that was published, about 7 years ago now, where they took, and these were premenopausal women, and they had them give a voided urine sample as well as they catheterized them like very soon after. So they got two kind of paired specimens. And they were looking to see how often the voided urine result compared or predicted the catheterized result, okay? So when you had E. coli in a voided specimen at pretty much any, colony-forming unit per mil, so at any kind of degree, it correlated very well with if they did a catheterized specimen. Whereas if you had enterococci or group B strep in a voided urine, it wasn't all that great at predicting that it would be in the catheterized specimen, suggesting that sometimes, and not uncommonly, these can be more contaminant, like when they're voiding that you're getting just group B strep and enterococcus from the perineal area. So these are relatively small numbers here, so you'd have to take this a little bit with a grain of salt, but just realize that especially if it's a mixed infection, that this might be more likely to be more contamination than true infection. So I'm going to go over some of the clinical syndromes of UTIs, and there's a lot, believe it or not. Everybody thinks UTIs are so simple, but it's not. I'm going to focus a little bit on the lower urinary system tract syndromes, so cystitis, kind of urethritis is just kind of in that spectrum of cystitis and urethritis. We'll talk a little bit about pyelonephritis, so the upper kidney infection. I'm not going to talk a whole lot about perinephric abscess. I won't even discuss in any detail emphysematous or xanthogranulomatous pyelonephritis. Those are kind of special cases of pyelonephritis. Prostatitis I'll discuss briefly. I'll talk about asymptomatic bacteriuria. I'm not going to talk about catheter-associated UTIs this year. I think I discussed that last year or the year before. And then realize there are special issues with UTIs related to the different host populations. So premenopausal women are different than the elderly, or spinal cord injured patients, or pregnant women, men. I mean, these all have their own unique kind of take on these clinical syndromes. So let's start with lower urinary tract infections, and this is probably more an outpatient issue. So cystitis and urethritis, usually patients are afebrile. They have some sort of lower urinary tract symptoms, so dysuria, urinary frequency or urgency, maybe some hematuria. And when patients present with those lower urinary tract symptoms, UTI is estimated to be the cause in only about 30 to 60% of those patients, depending on the population study. So realize that just because somebody presents with these symptoms, it doesn't mean it's a knee-jerk, like, oh, they have a UTI, let's give them some antibiotic. So what are the other things that can cause these symptoms? Genital tract infections are very important and very common in sexually active young people, even older people. So think about gonorrhea, chlamydia, Candida vaginitis. Bacterial vaginosis isn't as much causing those sort of symptoms, but trichomonas certainly can cause dysuria, herpes simplex virus infections, et cetera. And then there are other causes for some of these symptoms as well: vaginal atrophy, chemical irritation, any trauma. Interstitial cystitis is kind of an interesting entity, that it's not an infectious agent that causes these symptoms, but there's inflammation in the bladder. Benign prostatic hypertrophy can cause urinary frequency in men. Catheters can cause irritation. Stones can cause pain. When you see painless hematuria, you obviously need to think about bladder cancer. So if somebody presents just with blood in the urine, don't immediately jump to a UTI. Again, I've had several cases over the last 20 years or so that I've been here that people were treated as a UTI and they ended up having bladder cancer. So painless hematuria, again, think bladder cancer as a possibility. So again, I'm kind of emphasizing this issue about the overlap between urinary tract infections and genital tract infections, because this is something we saw commonly when we did this study in the emergency department. And if you work in express care or in a primary care setting, especially where you have a lot of sexually active people, there's a frequent overlap of these symptoms: dysuria, frequency, urgency, suprapubic pain. Even some of the lab testing, you can have leukocyte esterase, you can have pyuria with chlamydia and gonorrhea in the urine. You can have these kind of signs and symptoms. So what kind of questions would you ask people to tease out if it's a UTI versus a genital tract infection? You ask them if they've had any vaginal discharge, any urethral discharge, any odor, lesions, abnormal menses for women, any pain with sexual intercourse. Have they had a new partner within the last 90 days or more than one partner within the last year? And do they maybe have some external dysuria? Some people use this sort of thing where the pain is more like when it's coming out, that there maybe is a lesion there, rather than that kind of bladder pain that some people describe. And so one of the big things, again, is really asking about vaginal or urethral symptoms. So make sure you do that sort of thing. This was a systematic review published almost 18 years ago now that looked at, again, these combinations of symptoms. So they used a pretest probability of about 50%, which is what I told you just a slide or two ago. And then they looked at specific combinations of symptoms. So if someone had dysuria and frequency, and they did not have vaginal discharge or irritation, and this was mainly in women, this was done, then your post-test probability of a UTI went up to like 77%. If, however, they had vaginal discharge, irritation, and they did not have dysuria, then your post-test probability went way down. And again, I'm not sure why these are all off, but they were not off in my computer. So it went down to 4%. And then importantly, and again, I see this in the ED not infrequently in the emergency department, if someone has dysuria or frequency and they have vaginal discharge or irritation, the post-test probability of UTI is like 9%. So really ask these questions about any genital tract symptoms when someone comes in with dysuria or frequency. Okay, so moving toward upper urinary tract infections. So pyelonephritis, the typical signs and symptoms of this would be fever or significant leukocytosis. You can have flank pain, nausea and vomiting, and you may or may not have any symptoms of cystitis. You might not have any lower urinary tract symptoms. Female, young women can present with just fever and flank pain or just nausea and vomiting without dysuria and have pyelonephritis. Bacteremia can develop in 20 to 30% of cases, so it's not uncommon for even uncomplicated pyelonephritis. Renal abscesses, perinephric abscesses, similar kind of presentation. It can be either a hematogenous seeding of the kidney or it can be an ascending type of infection from a urinary source. Often this is related to having stones, recent surgery, some trauma, and diabetes is certainly a risk factor for these more complicated infections. So prostatitis is divided into kind of 4 different categories. There's acute bacterial prostatitis, which is not that common, really. It's estimated to be less than 1% of all cases of prostatitis. And these patients are sick. I mean, they're really ill. They have fevers. They have suprapubic pain. Sometimes urinary obstruction just because of how inflamed the prostate is. So again, they're pretty sick. Then the second entity is chronic bacterial prostatitis. And this is people that you may see in the outpatient setting. They're not that ill. They have some lower urinary tract symptoms. They may have some perineal discomfort. And kind of the hallmark of this is they get recurrent UTIs, that they seem to be like, have the same bug. They just had an infection and then, they're coming back again with the same bug, same infection. In a man, you should definitely think about chronic bacterial prostatitis. And then these last 2 entities are chronic pelvic pain in the absence of infection. It can be inflammatory or non-inflammatory. And then the 4th thing is really just asymptomatic inflammatory prostatitis that is found incidentally on biopsy. So asymptomatic bacteriuria, very important that you understand this entity. This is defined as a positive urine culture in someone with no signs or symptoms that are attributable to a urinary tract infection. So it's a positive urine culture, but again, they don't have a symptomatic UTI. You can have pyuria in asymptomatic bacteria. So just the presence of white cells doesn't mean somebody has a symptomatic UTI that needs treatment. We don't treat asymptomatic bacteriuria unless someone is pregnant or before certain invasive urologic procedures. So the guidelines related to asymptomatic bacteria were just updated last year, and this is an update from 2005, so they've been around for a very long time, this concept of asymptomatic bacteria. And the prevalence varies based on the population being studied. So it's very uncommon in children, in healthy, like premenopausal women, maybe up to 5% or so. But then when you move down these other categories, and I've highlighted 2, elderly persons in long-term care facilities, so these are all these nursing home patients that you may see, it can be up to 50%. So if you just go to a nursing home and you get urine cultures on all the patients, whether they're symptomatic or not, about half of them may have a positive urine culture. And then when you look at persons with indwelling catheters, so Foley catheters, short term, you develop bacteria at a rate of about 3 to 5% per day. Long term, almost 100% of them will have bacteriuria by 30 days of having that catheter in before they change it again. So it's extremely, extremely common to have bacteria in the urine in those patients. So when the guidelines were updated last year, they added some things from previous guidelines in the past, and one was related to this issue about what do you do with older patients who can't give you a good history and you're not sure if they're symptomatic or not. And so they added several statements related to this. These are strong recommendations but with very low quality of evidence, that if an older person presents with acute mental status changes without local genitourinary symptoms or without other signs of systemic infection. So they don't have fever, they're not hemodynamically unstable, you know, they just have mental status changes, then absolutely think about other causes first. You know, don't immediately assume it's from the bacteria in the urine before you would, you know, throw antibiotics at them. And I'll give you an example of a case at the end here. Same goes with patients that fall, and this used to be a common, I think nursing homes have gotten much better at this, I think. But in the past, you know, somebody would fall, maybe they tripped, and they'd send a urine culture, it would be positive, and next thing you know, they're on antibiotics. So if they haven't had any genitourinary symptoms, they have no other signs of systemic infection, then absolutely assess them for other reasons, you know, medications or other causes before you would jump to the conclusion that it's a UTI. Now, I'm not saying that acute delirium in an older person can't be a sign of a UTI. It absolutely can, but you have to assess for other things as well. And then the recommendation was also not to send urine cultures for screening for asymptomatic bacteria for other procedures or other surgeries. It's really only for urologic surgeries. So what is some of this data behind these recommendations about not treating asymptomatic bacteria? Actually, there were at least 5 randomized controlled trials that showed no benefit from treating these patients if they had just a positive urine culture without any symptoms. And these were done in different populations: ambulatory women, institutionalized veterans, et cetera, all these populations, a lot of them in older populations. And the important thing to note here is that there were no differences in the rates of symptomatic UTI or mortality, you know, if you gave or did not give antibiotics, but the people that got antibiotics had increased rates of adverse drug events and reinfection with resistant organisms. So you're actually doing more harm than good by treating these patients with antibiotics. Okay, so now we're going to move to the lab testing for UTIs. So this is just a screenshot of a urinalysis that you might see. So you can do a dipstick, and you would get the top portion of this sort of thing, or just a urinalysis. And then if you order a UA in the system here, rather than just doing a dipstick in the outpatient setting, you will also get a microscopic exam if there's a protein that's abnormal, if there's blood that's abnormal, or if the leukocyte esterase is abnormal. So that's just here at Metro is how we have an algorithm for when to do a microscopic exam. And then we have another order here called a UACC, which is a urinalysis with complete culture. It is, that's how the UACC title came, but it's kind of like a reflex culture, basically. And if you put in an order for a UACC, they're going to do the whole urinalysis, and then they will only do the culture if there's a positive leukocyte esterase or a positive nitrite, or there's some evidence of pyuria. Otherwise, a urine culture will not be done. So this is a useful thing to do in someone where you have a kind of an intermediate suspicion for a UTI, where it can prevent all these urine cultures being done if there's really no evidence or no strong evidence for a UTI based on the urinalysis. So I'm going to go, the 2 things really on the urinalysis that we look at, or 3 things really, are the leukocyte esterase, the nitrite, and then the white blood cells in the urine. I mean, I'm also looking at blood in the urine too, but that can be due to other things as well. So let's go over what these tests really test for. So the urine nitrite results from bacteria converting nitrates to nitrite. So there can be false negatives and there can be false positives with this. And when I say, I'm referring to like a symptomatic UTI. So you can have a positive nitrite and not have a symptomatic UTI because this can be positive with asymptomatic bacteria from contamination. Patients that are taking pyridium or azo over the counter can have a false positive nitrite test. And you can have false negatives too. So not all uropathogens produce this nitrite. So a lot of the gram-positives, actually none of the gram-positives really do this. Pseudomonas doesn't. So there can be a number of reasons why this test might be negative when they have a true UTI. The urine leukocyte esterase results from the activity in the enzymes in the white blood cell in the urine, and it detects like 5 to 15 white blood cells per high power field. Some false negatives would be if you have very high levels of glucose in the urine, if they've recently been on some antibiotics, significantly elevated specific gravity. False positives, again, the point here is that genital tract infections can cause white cells in the urine. If you have contamination by vaginal discharge, you can see white cells in the urine. Catheters and stones by themselves can cause white cells in the urine. Asymptomatic bacteriuria, again, I mentioned you can have white cells in the urine, as well as others. So with the microscopy, we define pyuria. Different institutions define it differently. Greater than or equal to 5 white blood cells per high power field. And adult patients with symptomatic urinary tract infections almost always have some degree of pyuria. I'm not talking about neutropenic fever patients or somebody where they don't have white cells to begin with, but most patients should have some degree of pyuria if they have a symptomatic UTI. Now, the flip side, though, is that if you have white cells in the urine, as I've been stressing throughout this whole lecture, is it doesn't necessarily mean you have a symptomatic UTI. So this was an article published in 2015 in the New England Journal of Medicine that listed a whole bunch of reasons why you could have white cells in the urine that are not related to a bacterial infection. And again, we'll go back to the gynecologic infections, urethritis, appendicitis can sometimes do it, even like non-infectious things, catheters, stones, etc. So there are many reasons you can have pyuria. And then looking at the operating characteristics of the leukocyte esterase and nitrite tests, and this was to predict bacteriuria and or pyuria. So this is not even to predict like a symptomatic UTI. But realize none of these tests are great, like having one or the other. There's a wide range of positive and negative predictive values. The one thing that was stressed was that if they are negative for both leukocyte esterase and nitrite, then the negative predictive value for having significant bacteriuria or having pyuria was pretty good. So again, it's just harping on the negative predictive value of the urinalysis. So urine cultures. So urine cultures are performed as semi-quantitative cultures, and they're reported out as colony-forming units per mil. And there are different degrees of bacteriuria that are considered significant for different hosts, and this is based on a lot of old data from the 50s, honestly, and then some in the 70s and 80s as well. So for instance, for premenopausal women who have urinary symptoms, a colony count as low as 10 to the second per colony-forming units per mil can be significant and reflect a true UTI. For catheter-associated UTI, the cutoff can be a little bit different. The point here is it's all about the symptoms. So if they have some bacteriuria, they have symptoms, and the organism seems to match with, that could be a true pathogen, then it very well may be significant. So I wanted to go over this, I added this slide this year because it seems like I've had questions about this a few times over the last few months. So the reason when you put in a urine culture, you have to put what the source is. Was it from a midstream voided urine? Was it from a catheter? Was it a straight cath? Or was it a cystoscopy sample? And the reason for that is the lab does a different inoculation procedure depending on the source of the urine. This is based on standard microbiologic standards. So they use 1 microliter inoculation for these kind of specimens, 10 microliter for this. And when you do the semi-quantitative counts, they plate this on a agar plate. One colony, because they're plating 1 microliter, 1 colony is equal to 1,000 colony-forming units per mil, okay? In this situation, 1 colony is equal to 100 colony-forming units per mil. So they do this because they use these different inoculation because in this situation, you're able to detect lower amounts of organisms. So in a cystoscopy, even like 100 or 200 colony-forming units per mil might be significant, or if you're getting it from a kidney or something like that. Now, realize the maximal possible read you can get when you use these 2 different loops. For this situation, you can go greater than 100,000. However, when you're using this loop or this thing, you can't report like if it's more than 10,000. So the point is here, sometimes people tell me, oh, they didn't have significant bacteriuria, it was like 10,000. And when I look at the report, it says greater than 10 to the 4th or greater than 10,000. The only reason it says that, again, is that they can't count all those, all those colonies accurately to that degree. So they can't say it's greater than 100,000, but it's high, okay? So again, it feels like I've had several instances where that's come up, so I just want to make sure that that's clear. And then the other thing that people get confused about sometimes is how we report urine cultures. And again, this is standard from the College of American Pathology. So if a culture report says any colony-forming units per mil, no significant growth, skin or urogenital contamination present, that's a negative urine culture, okay? There are no uropathogens present. There might be something like diphtheroids or lactobacillus or something, but there are no uropathogen present, so it's a negative urine culture. On the flip side, if you see, X number of colony-forming units per mil, multiple bacteria present suggesting contamination, that's a contaminated urine culture that is a mix of organisms, some of which might be a uropathogen. So there could be E. coli in there could be Klebsiella, there could be anything, but there's a lot of them there, like 3 or more different types of organisms. So you can't know for sure if it's, if it's just a contaminated thing or they actually have a true infection with one of those organisms. So that's considered a contaminated culture. So again, when you get a positive urine culture, you think, is this contamination? Is this colonization like asymptomatic bacteria, or do they have a symptomatic UTI? Okay, so this is a very busy chart, but the point here is this is, I thought it was useful. It's in, I think in Harrison's or something, where they have the clinical presentation, they have kind of the host, and then what you would do for workup. So when you're suspecting a UTI and someone has lower urinary tract symptoms, there have been a number of guidelines or things that would suggest that you don't even have to send a urine culture, just treat them empirically. I'm a little bit hesitant about that nowadays, especially because of all the resistance that we're seeing, the increasing resistance in uropathogens, and because a lot of these patients don't even have a UTI, when I've reviewed a number of these. So my personal feeling is that I think we underutilize urine cultures in cystitis, and we probably should be doing that more often. For pyelonephritis or upper UTI or prostatitis, you absolutely have to get a urine culture every time. These are significant infections, and if you don't treat them appropriately, it can lead to very adverse outcomes. So you want to get the urine culture up front so you know what you're treating. For asymptomatic bacteriuria screening in pregnancy or before urologic procedures, you really just need a urine culture. You don't need the urinalysis to help guide your therapy. Okay, so for treatment, if you have cystitis, so a lower urinary tract infection in an uncomplicated host, so somebody without any structural or functional abnormality of the urinary system, and if the prevalence of bacterium resistance in the E. coli is less than 20%, and for us here, when we've done kind of a surveillance of kind of uncomplicated hosts, look at their rates of resistance, we hover around 20 to 22% bacterium resistance. So I think it's still reasonable in a healthy young person who comes to your clinic, who hasn't been on a lot of antibiotics, who isn't, complicated in any way. Bacterium is still certainly a reasonable option for treatment, and it's only 3 days duration for uncomplicated cystitis. Or you can use nitrofurantoin for 5 days. That's for just an uncomplicated cystitis. Fluoroquinolones are no longer recommended first line for uncomplicated UTIs just because of increasing resistance from all the collateral damage and adverse effects that have been associated with fluoroquinolone use. So that really is, if you can't use either one of these, then you can consider a fluoroquinolone for 3 days. Phosphomycin, a single dose, is a little bit less effective than these other agents, and it can be expensive. We do use it for ESBL, kind of lower tract urinary infections, or you can use a beta-lactam, Keflex, or something else for 7 days. In men or complicated hosts, it's still recommended to treat a little bit longer, maybe 7 days of therapy. For pyelonephritis, here fluoroquinolones are a reasonable option because it allows you to treat a little shorter. So there's good data for 7 days of ciprofloxacin if it's a susceptible organism. If you're using Bactrim or beta-lactams, 14 days, some data for 10 days. There was even some data for shorter course with very early pyelonephritis, but I usually stick to 10 to 14 days if I'm using Bactrim or beta-lactams. We don't use nitrofurantoin or phosphomycin for upper urinary tract infections. These drugs are not well absorbed or get into the kidney well at all. They're good for the bladder, but not for kidney infections. So do not use those for pyelonephritis. And then you base your final treatment based on the susceptibility pattern of the pathogen. Always consider, patients' allergies, their prior antibiotic use, look at their prior urine culture results, And renal function is important, especially for nitrofurantoin, because you can't use that if somebody's creatinine clearance is less than 30 or 40. So complicated pyelonephritis might require even longer therapies. So those are people that have stones or other issues that make it much more complicated, or an abscess or things like that. Catheter-associated UTI, we treat for 7 days if they have a quick response. Sometimes we go longer, 10 to 14 days if it's a slower response. For prostatitis, in general, the treatment is for 2 to 3 weeks for acute kind of thing, up to 6 weeks, but it can be often longer for chronic prostatitis. For asymptomatic bacteriuria, we treat before a urologic procedure, usually a single dose prior to the procedure. In early pregnancy, treatment durations are 4 to 7 days. For complicated infections, you often need adjunctive therapy, such as surgery or drainage procedures as well. So the other area I wanted to talk about was treatment failure. And I define these 2 different ways. You can have non-response or relapse, or you can have a recurrent infection. So first we'll talk about non-response or relapse. So non-response means that they've been on antibiotics. It looks like it should be susceptible to this antibiotic, but they're not getting better after 3 days. Relapse would be that they got the antibiotic, they responded, but soon after starting, it came right back with the same organism. That's usually defined as within 2 weeks. So some of the reasons why somebody might have relapse or non-response could be if there was an unresolved, kidney infection. You treated them for 3 days with Bactrim, and they actually had pyelonephritis, and they needed a longer duration of therapy. If there was some stone or foreign body that was causing, that needed to be drained, let's say, or the stone needed to be removed. If they have a prostate infection, that usually requires much longer therapy. Sometimes it's just because they have persistent colonization with that infecting organism, and whatever risk factor they had for UTI is still present, and they just keep getting infected with that organism. And always, always considering structural and functional abnormalities of the urinary system. So that's non-response or relapse. For recurrent infection, that is more that they respond well to treatment, and they do well for a while, but more than 2 weeks, they're doing fine, but maybe like in 3 months, they get another infection, and it kind of comes back. So this is not uncommon in sexually active women, and you usually don't need to do any major, urologic evaluation, but in other cases, urologic evaluation may be indicated. So for recurrent infection, if someone has had more than 3 UTIs per year and no significant identifiable underlying urologic complication, you could consider these different treatment options. And this is in a discussion with the patient. So sometimes women have 4 UTIs per year and they're fine with just treating each episode as it comes. But for some people, you can do different things. First, you can give them patient-initiated treatment. So at the first sign that they think they have a UTI coming on, they have an antibiotic script to start their treatment. Second kind of option is postcoital treatment. So if their UTIs seem to be associated with sexual intercourse, there is data for giving a single dose of an antibiotic after intercourse to help prevent UTIs from occurring. So this is an option. For postmenopausal women, there is data for topical estrogen cream, which I'll show you soon, and I've certainly recommended that to a number of older women that I've had in my practice who have recurrent UTIs. There's some data for increased fluid intake. I'll show you a recent article that was published. Low-dose suppressive therapy, I try to use this as a last resort, being an antimicrobial steward. However, there are women, older women, that really benefit from this, that are on low-dose macrobid or low-dose Keflex at bedtime or Bactrim and do well for a while. I usually reassess them every 6 months to decide if that's what we want to continue or not. The issue about cranberries, there was a Cochrane review that suggested a small trend to reduce UTIs, but it really wasn't statistically significant. There's no standardized cranberry product. It's all over the place. You'd have to drink a lot of cranberry juice, and if you have diabetes or something else, it's not a good idea. And usually they're using the drink rather than the juice, and the drink has a lot of sugar in it and stuff. So I don't push the cranberries. And I didn't put any comments about D-mannose. So there are some urologists or other people that are using D-mannose. I don't think the data is that great for that, so I don't usually prescribe that. So this was the data from way back in the early days, 1993, for postmenopausal UTI prevention using topical estrogen. And in this study, they randomized people to topical estrogen versus placebo, and the symptomatic UTIs were much less frequent in the topical estrogen group compared to the placebo group. They had 0.5 UTIs per patient year compared to almost 6 in this category. And this is the kind of the Kaplan-Meier analysis showing the proportion of women who remained infection-free over time. This goes out to 8 months. And then just 2 years ago, there was this study published about increased fluid intake. So this was about 140, I think it was all women, who had like a baseline fluid intake of less than 1.5 liters of fluid per day, and they randomized them to drinking like 500 milliliters of fluid 3 times a day, so an additional 1.5 liters of water every day. And then they followed them over the course of 1 year, and to see how frequently they would have, UTIs. And so the water group is the dark green. So on the y-axis is the percentage of women who have, episodes of recurrent cystitis, and these are the number of episodes of cystitis. So the water group in green had fewer recurrent cystitis episodes over this 1 year period compared to the control group, where they had 3, 4, 5, episodes of UTIs. And then they looked at clearly the urine volume in the women in the water group was much higher than the control group, so they were peeing much more, and they were going much more frequently. So if they're going to do this, they're going up to like 8 times per day compared to somebody that might be going like 5 or 6 times per day. So that might be one strategy you can use to help prevent UTIs. Okay, so that was kind of a quick overview of UTIs. So I was just going to go through a few cases just to try to drive home some of these points here. And these are real cases. I tried to copy and paste from the electronic medical records, so they're not polished very well. These are from actual patient encounters. So the first was a 44-year-old lady who came to express care for painful urination beginning a day ago. She had urgency, frequency, abdominal pain. Last menses was in during that, shortly before this visit. She's been taking Aleve and Azo, and a lot of these women take Azo over the counter. She denied fever, nausea, vomiting, chills, fatigue, hematuria, low back pain. This didn't come out, but I think this was all negative. She had no white blood cells in the urine. What do you think? What would you do next, I guess? Okay, first, do you think there's any evidence of pyelonephritis here, number one? So there's no symptoms of an upper urinary tract infection, so no fever, nausea, vomiting, flanking, nothing there. So we have lower urinary tract symptoms in a young woman, and the UA isn't that impressive. What else do you want to ask her about? Okay, yeah, so ask her about, yes, vaginal symptoms, anything going on there. So what happened here, because again, there wasn't a lot of white cells in the urine, there's not, it's a little bit suspicious for maybe she doesn't have a UTI. Well, she was prescribed nitrofurantoin for 5 days. They did get a urine culture, which was nice, but no growth, no STI testing was done. Then she followed up, I think a week later, and she had those symptoms. She had been on Azo. She had completed the macrobid, and she was better, but she wanted to get rechecked to see if the infection was gone. So do we do a follow-up urine culture? I didn't mention this, but no, it's not recommended to do a follow-up urine culture for a test of cure. Again, the urinalysis was pretty unremarkable here, and this was the culture result. It had 1 to 10,000 colony-forming units of group B strep, and if you read below here, 10 to 100,000 of just skin and urogenital contamination present. So what do you think about this culture? Do you think she has a group B strep UTI? Yes or no? Okay, no. Okay, so she's better. She has no symptoms. I mean, there's many reasons why she probably doesn't have this. Urinalysis is completely negative. Now, the lab is kind of required to report group E strep on women of childbearing age, just because sometimes that affects if they're pregnant and you need prophylaxis for group E strep. This is kind of a lab thing. So unfortunately, they do have to report it. So no, I don't think she has a UTI. She was given Keflex for 7 days. And then she came again for more pain. Anyway, it goes on and on. But this is one where I would say, you know, we should have done STI testing or some other genital tract testing. And she got a lot of, 2 courses of antibiotics that I think were not necessary. Okay, so the next one is a 32-year-old female who presented to Express Care. She had low right back pain. She said every time she moved, it was painful. She had frequency and dysuria. She was feeling nauseous. Her urine was cloudy. She had blood in the urine. She denied any fever, bladder infections. She is sexually active. Her urinalysis showed large leukocyte esterase, positive nitrite, more than 100 white cells. She had some blood. This was, again, Express Care. They didn't do a urine culture, and they treated her with Bactrim for 3 days. So what do you think about that? What do you think the syndrome is here first? I think I heard somebody. Right, so the concern is for pyelo here. She has kind of right-sided flank back pain. She has nausea. She doesn't have fever, but it's a little concerning for pyelonephritis. And if we're worried about pyelonephritis, what should have been done here? The urine culture should have been done. Okay. And if we're treating for pyelonephritis, would 3 days be enough? No. So we'd probably do more like 10 to 14 days. Okay, so she took her 3 days of Bactrim. She still was having burning with urination, no blood. She had this persistent right flank pain, if you will. She said, well, maybe I was working out, I'm not sure, but she definitely had some flank pain there. So she went back to the ED. They did a CT, and she had mild right hydroureteronephrosis, urothelial thickening, the collecting system, no stones. So then they said the UTI must be resistant to Bactrim. They gave her IV ceftriaxone, discharged her on Keflex for 7 days, and a urine culture was ordered. Okay, so duration was a little too short here again if we're treating pyelonephritis. Absolutely great that they did the urine culture. So here's the urine culture. And if you remember the first slide of the New York Times article, so we have an ESBL E. coli. This is not somebody that's been in the hospital. These are outpatients, young, healthy people that we're seeing with this ESBL stuff nowadays. So she went back to the ED. She was given IV Zosyn and sent home on Macrobid for 7 days. What do you think about nitrofurantoin? Okay, why would you not give nitrofurantoin in this situation? Say it again. I think I heard it. If we're worried about pyelonephritis, yes, because it's pyelonephritis. So Macrobid is good for cystitis, not good for the kidneys for pyelonephritis. So then I saw her in clinic after that. Her dysuria was better, but she was still having this, flank pain after urinating, some chills, this and that. So she was treated with IV ertapenem as an outpatient, and she responded well. Okay, this one is a 68-year-old man with metastatic prostate cancer, had a long-term Foley catheter due to urinary retention, who was having relapsing symptomatic UTIs due to Pseudomonas. So his history started in like August when he had urinary retention and a Foley catheter was placed. A month later, he was diagnosed with metastatic prostate cancer. 2 months after that, he had this left groin pain radiating to his testicle, associated with testicular swelling and tenderness to touch. He had had a catheter change approximately a week prior to that, and had some increased leakage around the catheter, a lot of pain. His culture grew Pseudomonas, and some Enterococcus was in there as well. So he was treated with fluoroquinolone for 10 days. So what is this syndrome here? So this is kind of a catheter-associated UTI, but it's kind of orchitis. He definitely had testicular swelling and tenderness to touch, so kind of an epididymo-orchitis. Duration of treatment is usually 10 to 14 days for that sort of syndrome. So then and this was within actually a short time. He developed bladder spasms, leakage, blood in the urine, pain. He described it at the tip of the penis and after sitting for prolonged periods of time. Urine culture had the same, Pseudomonas, and did have a little Enterococcus still in this one. Actually, I hadn't seen him at this time, but he was treated with Cipro for 14 days for, try again. Came back again, and usually this is within 2 weeks of finishing his treatment where he relapsed again. And this time he landed in the hospital with hypotension, urinary symptoms, and had Pseudomonas again in the urine. And he was treated for 2 weeks again with Cipro. And then, somehow, I can't remember all the time with this, but then I think he had a CT along the way, or I saw him, and he had a kind of periprosthetic, perirectal kind of abscesses, so kind of a prostate infection here that required much more prolonged duration of therapy. So again, this is an example of relapsing infection in a man. Certainly think about prostate infection, why it keeps coming back. And then I'll just do 1 or 2 more here. This was a 56-year-old man with a spinal cord injury, has a neurogenic bladder with a suprapubic catheter. Again, he describes this episodes of burning in the penis, leakage of the urine through the penis. His catheter is frequently blocked. His urine culture had this result here, so greater than 10,000 Proteus, which again means there's a lot there. Okay, it's not a, it could be 100,000, it could be even more than that, but it's greater than 10,000. And he had relapsing symptoms within a few days of stopping therapy. So I would treat him, and then within, 2 weeks, it'd be back again. So what would be something to consider in this situation? Think about the organism here too. So what did I tell you about Proteus at one of the earlier slides? Stones, yes. So stones are important. So he had a CT urogram, had multiple stones in the bladder, one very large one that was, got him to urology and got that removed. Okay, I'll do one last one here. So this was a 91-year-old healthy female with recurrent UTI. So she was getting approximately 4 per year or more. And it was bothersome to her, and she wanted to do something about it. So what would you recommend? And she typically would have this culture. So what were some of the strategies for dealing with recurrent UTI? In this person in particular, so this is an older woman. So topical estrogen therapy is what we recommended, number 1. And then sometimes it seems like that can take a little while to kick in. So we did end up putting her on some suppressive therapy as well for a period of time just to see how she'd do. So we gave her macrobid, nitrofurantoin, to take at bedtime. What would you have to be sure of? If you're prescribing a 91-year-old macrobid, what are you going to check before giving this? For kidney function, yes. So you do not want to give macrobid if the creatinine clearance is, they've actually dialed it down a little bit. So if it's less than about 30 or 40, you don't want to give macrobid in that situation. Okay, I think we're at time. So sorry, no time for questions, but I'm happy to take any questions afterwards if you want to ask anything.